patrons and presidents, sir, and all those Kasoga presidents, sir, Durgadas, sir, and Bellas, sir, who has joined, and all my dear seniors and my teachers who have joined. I thank Varun Thakur, sir, for making this happen. Before I could give a brief introduction, as we all begin with the small prayer, I ask Mr. Arun to please, we'll begin the session with the prayer. Arun, sir, please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. Thank you so much. So, on behalf of Imaging Committee, I welcome you all for this fifth session of our from our committee. So we are late by 1 week, and we had to postpone after the festival. So post festival, with blessings of Almighty, we'll go ahead with our most important topic that we are going to cover, because we all obstetricians are very much familiar that we all are doing dating scans or a check scan to say that whether she is pregnant or not. And on that particular scan, what all we can really know, and what are the mistakes we're actually doing in knowing this, and how important is that to date a scan such that we are not going wrong with the biochemical tests that we do, and also the EDD that we are going to calculate. So I seek Dr. Durgadas Arsana sir to give his blessings, so that we will go ahead with the program. We have invited speaker, that is Dr. Varun Thakur sir. He's from Pune, a very young and a very dynamic fetal medicine consultant. Sir, Durgadas sir, we welcome you for this program, sir. Thank you so much for joining in spite of a busy schedule. We know we all have Kasoga this month end. I request everyone who has joined here and also in your groups that please make it that we all make it to Kasoga, and want to make it a big grand success one, because this is what we all are looking forward. And sir has put a lot of effort to bring in new things and new implements this time to show us all. So sir will take it's your take, sir, please. Welcome, sir. Thank you so much.
Good evening, everybody. Thank you, Raju, for the opportunity.
Yes,
At the outset, I seek the blessings of Almighty and happy Dasara to one and all. Coming to the today's topic, first of all, I congratulate Dr. Raju Giradi for his excellent what he is doing. As he told, today is his fifth program. You can see the logins are coming nearly 100. I know it's every time it's going to cross more than 100. This is, I can say that this is the only webinar we are crossing 100 almost every time. That is the sanctity of the webinar what Raju is giving to Kasoga.
thank you.
Okay. Coming to the topic as such, dating scan, as Raju told, it is one of the most important topic, because as all of you know, current India is the capital of premature deliveries. The number of premature deliveries occurring in India is almost one of the major junk. We have become the capital of diabetes. We have become the capital of obesity. Now, another problem is the prematurity, and one important thing is the wrong dating, wrong EDD. Maybe you can say it is iatrogenic because of the wrong dating scan. All starts from the dating scan. If your dating scan is not proper, your EDD will not be proper, and you are bound to land up with premature babies. And to prevent the prematurity, incidence of prematurity in India, we have to have the basic dating scan should be proper. And such a good topic Raju has selected. on the one side. Another thing, as I heard, Dr. Varun, the young sonologist, is doing marvelous job in Pune, and he is one of the genius in with respect to the radio diagnosis. With these few words and uh, congratulations to Raju. See, it's already reached 100. I know every time you are going to cross this. With these few words, the best part is you may not be knowing. I met few gynecologists in Calicut and Bhubaneswar conferences. They were telling that they are logging to this program, Raju's program. Raju, I don't know whether you know this or not. One lady who is working in defense, she's an obstetrician. She's working in Himachal Pradesh. She is logging the two programs she is logging from Kasogais. One is yours, another is Prabhades. I was so happy that I have selected you, both of you. Raju, you are doing the justice to the post what you have taken. With
Sir.
these few words, I don't want to take any more time. Once again, congratulations, Raju, and I'm eagerly waiting to hear Dr. Varun's words. Thank
Yes,
you.
yes, sir. Sir, namaste, sir. Thank you so much for your very kind words and appreciation, sir. Because it's all because of your support and being the backbone of our society that you are encouraging us, sir. Yes, I don't want to waste more time. I have take Shobha Gudi madam has given her well wishes. She is not able to join. I seek blessings from all the seniors and my teachers here. So now I request Arun to please share the CV of our eminent speaker today, Dr. Varun Thakur, sir. Yes. So, Dr. Varun Ashok Thakur, sir, actually a brief introduction on him, but it's actually a great privilege and honor to introduce today our distinguished speaker, Dr. Varun Ashok Thakur. Dr. Varun is an emerging and a very highly talented consultant in fetal medicine. He is known especially for his humility, his passion for teaching, and his ability to make complex discussions, especially in fetal medicine, highly engaging and educative. He is always approachable. That is the most important thing that we all know among his colleagues and friends, and me being his junior. He is always approachable and ready to guide his colleagues, which makes him as an inspiring teacher and mentor. He has completed his MD in radio diagnosis from the prestigious KM Hospital, Mumbai. He has followed by his fellowship by our beloved Dr. Adi Sir's Fetal Medicine at Adi Sir's Advanced Center for Fetal Care in Bangalore. He is also an FMF UK certified in multiple areas, including fetal abnormalities like NT, the nasal bone, the DV, the preeclampsia screening, and the Doppler studies. He's one of those who keeps on updating himself and he keeps his data updated for the societies. And currently, Dr. Varun serves, he is a director and consultant at Sri Mauli Diagnostic, his own center at Mauli Diagnostic Centers at Pune. He is an active member of several professional bodies, including the Indian Radiological Association, the International ECOG Association, and the Society of Fetal Medicine, the SFM, where he is also holding the post of secretary. Presently, he is the secretary of Greater Pune chapter. Dr. Varun has presented his work on various platforms and was awarded the first prize in the Three Sundays with Dr. Rabi Shoy. Rabi Shoy is a very well-known figure that we have in fetal medicine, because without him, it would not have been boomed so much. And he is one of those of the young speakers that he has chaired the platforms with Rabi Shoy in India in international platforms. His special areas of interest include fetal imaging and interventions, and he has publications on rare and complex cases such as ectopia cordis, genu recurvatum, and cardiac genetics. With his rich expertise and passion for advancing fetal medicine, today he will guide us through one of the most important. Today he'll guide us through one of the most important fundamental topics in obstetrics, that is the dating scan. Though it is a routine part of our practice, it is essential to 1 second, sir. Yeah, sir is calling some problem with his 1 second, sir. Mr. Arun, can you help me out? That sir is not able to log in because the capacity of 100 has been filled, it seems. He has logged out
No,
actually.
sir, we have 500. 1 second, sir.
So please check, sir.
Yes, sir. Shall I stop sharing, sir?
Yes, sir. Yes, sir. No issues.
Ah. Varun, sir?
Varun
Yes.
is there, sir?
One
No,
second.
he is.
Can you send the number, sir? 1 second.
Sorry for the hiccup. Sir was not able to join. He had logged out, but now he's there inside. Sir, I was giving a brief discussion about sir. So today, with his rich expertise and passion for his advancing fetal medicine, he will guide us through one of the most fundamental topics in obstetrics, that is the dating scan. It is though a routine part of our practice, it is essential to refine our approach, avoid the common mistakes that we do, especially when you have an IVF pregnancy. We most of us date it very, very wrong, and that will affect our biochemical screens also. So, and we'll see how it is essential to refine our approach and avoid the common mistakes we do and identify and what all we can identify in this early scan. So Dr. Varun's insights and practical tips will certainly help us to improve the quality of our scans and definitely the patient care. So I warmly welcome Dr. Varun sir for this webinar that we conduct from the state organization. Thank you for giving your time and your permission to go ahead. Thank you, sir. We all look forward for your enchanting discussion that you're going to take us through the dating scans. I believe and I'm very sure, please be there till the last because his interactions are too good. We will assess ourselves how much we know and what mistakes we are doing and how better we can improve in that. So because dating scan is done by everybody. So I request all of you to be active in the participation. Whatever you know, you try to type in the chat, even if it is wrong. Please do that. Thank you. Sir, it's your, you can share your screen, sir. Varun, sir. Varun, sir, can you hear me? You have just,
Sir, he has muted his mic.
Raju sir, am I
is,
audible?
Yes,
Good evening, sir.
yes, sir, you're audible, but
audible, sir.
yeah, the sound is
It's
low.
not clear, sir.
There are some network issues, it seems, sir.
Yes, sir. Yes, sir.
Raju,
Sir,
can you ask him to share the presentation in mail? Arun can actually screen it.
Yes, sir. Yes, sir. Raju, sir, I'll send the mail ID right now.
yes, sir. Varun sir, if you have problem with that, I will share the mail ID of Varun.
He is not there now. He left.
Oh. Varun, sir.
Can you hear me, sir?
Yes, sir.
Yeah. Okay, so shall I share my screen?
Yes, sir. Please do, sir.
Yes, sir.
All right. So are my slides moving, sir?
No, sir. We are not able to. We are able
No,
to see
sir.
your home screen. That's it.
We can see the folder, sir. Only one file.
Is it visible now?
No, sir.
No, sir. Sir, just open the PPT and keep it in your desktop,
So
sir.
it is already
Ah,
open.
then you can stop sharing it this now, and then you can share that, sir.
All right, sir. I'll do that.
Problem is,
Is it visible now?
it's 1 second.
Yes, sir. Yes, sir. Now
Make
it
it
is visible.
slideshow, sir. Please.
Slideshow, sir.
Yes, sir. But some glitches.
Okay.
Good evening, madam.
All right. So, good evening, everyone. At the outset, I'd like to thank Kasoga and especially Dr. Raju sir for giving me this opportunity. Sincere apologies for the delay from my end because I'm having some technical problem with the bandwidth here. I hope I'm audible and my slides are clearly seen now. So at any given point of time, if you do not hear me or if you think that the slides are not moving, please let me know. Okay.
Sure, sir. Sure, sir.
So
Now
this
it
is a
is
very
clear, sir.
basic. Yeah, wonderful. So this is a very basic, basic discussion about early pregnancy evaluation. We all do these things on a daily basis. So it is imperative on our part that we know inside out about all these things. So those who know me, they know me very well that I do not talk on my, I don't talk alone. Most of my presentations are actually interactive. And so I would like, and I encourage all of you guys to please participate so that we can make most out of it. Okay. So the agenda of this talk is, of course, confirmation of pregnancy and dating in singletons. Then we'll have a look at some normal variants and the timeline of appearance of certain structures on ultrasound. We'll talk about early pregnancy loss. I've deliberately, erased that word failure because this is not used anymore. We now use the word early pregnancy loss. We'll also have a look at a few cases. And we'll run through twinning, the chorionicity part, dating and labeling of the twins. Okay. Now, I'm sure most of you do ultrasound on a daily basis. So I would want you guys to give me the correct answer for the following question. What is the correct timeline of appearance of these structures on ultrasound? Which structure appears first and which structure appears last? So G-sac appears first, then yolk sac, then embryo, then cardiac activity, and then amnion. Or G-sac, then embryo, then cardiac activity, then yolk sac, and then amnion. Or G-sac, yolk sac, amnion, embryo, and cardiac activity. And finally, G-sac, amnion, yolk sac, embryo, and cardiac activity. So I would like to wait for the answers. Please give your answers in the chat box.
Nice. So I request all of you to take participation in this. So I can find, sir, some of the answers that I'll read out. Most of them are choosing C as
Yeah,
the
I can see, sir. I can see. Wonderful.
very nice, sir. Very nice.
Many
Yeah, then it's very good, sir. Thank you.
Yeah, most of them have answered C, and a few of them have answered 4. So yes, very good. Thank you. Wonderful. So that is what is expected. You guys, please participate. And now we will see one by one what is the first structure that appears and what is the last structure that appears. Okay, remember whatever you have said. Yeah, this is going to be interesting. So moving on, all of us know that the first structure that is seen on ultrasound is actually the gestational sac, right? Now you guys tell me which of these is actually a gestational sac, the one on the left side or the one on the right side? Again, in the chat box, the left image is a gestational sac or the right image is a gestational sac? You can write left or right like that. Right. Superb. Wonderful. Everybody is writing right. So I'll give you the answer. I'll say none of them is actually a true gestational sac. I'll reiterate, none of them are a true gestational sac. The image on the left hand side is actually just fluid in the endometrial cavity, whereas the image on the right hand side is a GSAC like structure. You see, it is a GSAC like structure. It does not have any yolk sac or an embryonic pole inside. So it is called as a GSAC like structure, or you may call it as a probable GSAC. So what is a true GSAC? So we know that this is just a fluid in the endometrial cavity. A true GSAC would be a sac-like structure which has either a yolk sac or an embryonic pole inside. Only then you can call it as a true gestational sac. The previous image which we saw was only a GSAC-like structure. There was no embryonic pole or a yolk sac inside it. Also, a GSAC is typically eccentrically implanted in the endometrial cavity, and you can see the annotations which I have done. This is called as the intradecidual sac sign. So this is the intradecidual sac sign, which tells us that this is a true gestational sac and a true intrauterine pregnancy. So remember, if you just see a fluid
Varun, sir?
collection in the endometrial cavity,
Varun, sir?
even if it is, yes, sir.
Sir, sorry, can you use your highlight or pointer where we are not able to see that? If you are using
Sure,
so.
sir. Can you see now?
Yes, sir. Perfect, sir.
Wonderful. So I have made these annotations which show the endometrial cavity. Okay, this is the cavity, whereas the sac is eccentrically located in the walls of the endometrium. So this is a sign of a true intrauterine pregnancy, and this sign is called as the intradecidual sac sign. And a true gestational sac is actually a sac which has a yolk sac or an embryonic pole inside. Only then you can call it as a true gestational sac. Otherwise, you simply call it as a GSAC-like structure and not a true GSAC. So we all saw this. So this is a GSAC-like structure. Typically appears at around 5 weeks. Now, will you date at this point of time? If you see a GSAC-like structure, will you give her EDD at this point? In the chat box, yes or no? Will you date her? No. Yeah, wonderful. Yes. So we don't date her at this point of time. Absolutely not. Instead, we ask her to come for a follow-up after 2 weeks. We simply measure the mean sac diameter in 3 orthogonal planes. All of us, we know it. We do not date. Okay. So why did I say that this is a GSAC-like structure and not a GSAC is because this is recent paper which has come last year. This is a SRU lexicon. This paper, you can take a screenshot of this paper. Everybody should have this in their scan room and everybody should go through this paper. They have nice charts and images also. A very small read, half an hour, and you will complete this paper. This is a wonderful paper which tells us about all the terminologies that we should be using in the early pregnancy scan. So this paper actually tells us what is a GSAC and what is a GSAC-like structure and what is a yolk sac and so on and so forth. Moving on. So now this is a GSAC and a yolk sac. So this is an unequivocal sign of pregnancy. If you have a GSAC and a yolk sac, that means the pregnancy is confirmed. So this is typically seen at around 5.5 weeks. And of course, we will not date at this point of time. Rather, we will ask them to come after 11 days. And typically the yolk sac measurement is less than 6 millimeters. So now we have a GSAC and a yolk-sac. We call them after 11 days. Next step is the embryonic pole. You can see a tiny embryonic pole is seen here, which typically gives us a diamond ring sign. So that's the diamond ring, which is the earliest evidence of the embryonic pole. It can be seen as early as, say, 6 weeks or even 5 weeks, 6 days for that matter. If you can document the if you do not have a cardiac activity, then you follow up after 1 week. But if you have the cardiac activity, then you can date the pregnancy at this point of time. With the embryonic pole comes the embryonic cardiac activity. So almost always the embryonic pole and embryonic cardiac activity come together. And this is how we measure the embryonic cardiac activity. Use only M mode. Only M mode has to be used. Please do not use color Doppler. Please do not use pulse wave spectral Doppler. Only M mode has to be used. If you find difficulty in measuring the cardiac activity by M mode, you zoom the image appropriately so that you get a good picture, and only then you measure. But please do not use color Doppler or pulse wave Doppler, spectral Doppler in the first trimester. Okay. So embryonic cardiac activity typically appears by around 6 weeks. And once you have this, you do not call the lady again. Simply call her straight away at 12 to 13 weeks for NT scan. And as I've already mentioned, please do not use a color Doppler or a pulse wave Doppler at this point of time. Never till 10 weeks. And finally, the last thing that appears is the amnion. So you see, this is around a 7 weeks fetus. What we can see is a GSAC, a yolk sac, an embryonic pole, and then a thin amnion surrounding the embryonic pole. So the timing of appearance is GSAC first, then yolk sac, then embryo with the cardiac activity, and finally the amnion. So amnion is the structure that appears last, typically appears by around 7 weeks. And once you have the amnion, you already know that there is cardiac activity, and you follow up the lady at 12 to 13 weeks. So I hope I've made this point clear. That is the timeline. That is the way these things appear on ultrasound. Okay. Moving on to dating in ultrasound. So this is a committee opinion given by the ACOG, the AIUM, and the Society of Maternal Fetal Medicine. This was published in May 2017. This paper tells us how to date the pregnancy. Okay. So this is a chart which I've adopted from the paper. So if the pregnancy is, say, less than 9 weeks, then obviously you're going to use CRL. But if the discrepancy between the LMP and the CRL is more than 5 days, you redate the pregnancy. Between 9 to 13 weeks and 9 to 14 weeks, again, the method of giving the date is CRL. And if the discrepancy is more than 7 days, then you do redating. Likewise, between 14 to 16 weeks, you use all the biometric parameters like BPD, HCAC, FL. If the discrepancy is more than 7 days, then you redate. And between 16 to 22 weeks, if the discrepancy is more than 10 days, then you redate. And from 22 weeks to 28 weeks, if the discrepancy is more than 14 days, then you redate. You see, I find this paper rather difficult to learn, I mean, although I have the printout of this paper in my clinic, but I find this very difficult, 9 weeks, 9 to 14 weeks, 14 to 16 weeks, 7 days, 5 days, 10 days. So what I do is I typically date all my pregnancies by ultrasound. Okay. So that is perhaps an easy method. And even RCOG says so, that you should date all your pregnancies by ultrasound. Remember, whatever method you use, whether you use the AIUM method or you use the RCOG method, you should not change the EDD. If you have given one EDD, you should stick to that EDD forever, no matter what method you are using. Okay. So mandatory part is, please do not change the EDD. What method you are using to date the pregnancy is secondary. You can use this way also, or simply you can use the ultrasound way. Just by doing the ultrasound, you can date the pregnancy. Don't give two EDDs. Don't give two EDDs. You cannot have EDD by LMP as, say, 31st of December and EDD by USG as 25th of December. This will unnecessarily cause confusion. You simply give one EDD, no matter what it is. I don't even write in my report that it is EDD by LMP or EDD by USG. I simply write EDD. That's it. End of the story. And whatever EDD I give in the first scan, I will carry forward that EDD throughout. I will never ever change that EDD. And that is an important message we should all adhere to. So let's have a practice session here. What happens if we date, if we do not date, or if we date properly? So imagine this scenario. This lady has an LMP of 22nd of March 2024. EDD by LMP is 28th of December 2024. So by her LMP, she was 7 weeks, 5 days at the time of scan. And by ultrasound, she's 6 weeks, 6 days. So is there a discrepancy? Yes. So how will you date? Will you date by LMP or will you date by ultrasound? Wonderful. EDD by USG. But remember, if you are saying EDD by USG, I am assuming that you are doing your USG in the first trimester only by a transvaginal route. That has to be only exclusively transvaginal scan. You cannot date by a transabdominal. I mean, you can, but then accuracy differs. You know, transvaginal is way more accurate than TAS. So if you're dating by ultrasound, remember it has to be preferably a transvaginal ultrasound. So it has to be EDD by USG. Wonderful. So this was one of the scans that we did on the LMP was 10th of November 2021. By LMP, I hope you guys can see this, right?
Yes, sir.
Is it visible,
Yes.
Raju sir?
Yes, sir. Very much.
Yeah. So by LMP, it is 10 weeks, 2 days. Okay. But by CRL, it is 9 weeks, 1 day. So there is a discrepancy of 8 days. So obviously, as we have previously practiced, we will redate, correct? But what if I don't redate? You see, at anomaly scan, more or less everything is normal, you know, just on lower centiles. So at anomaly scan, this lady is 21 weeks, 5 days by her LMP, and everything appears to be fine, not a great difference. But as I move on to the growth scan, see what happens. Now all my parameters are falling down. All my parameters are less than 5 percentile, and my AC is also less than 10 percentile. So the software is suggesting me that this fetus is now growth restricted. But you see, I have not done the dating appropriately here. I have simply carry forwarded the LMP date, and that's why this has happened. So what happens when I redate this, when I go back? So instead of that LMP, I put it unknown, and now I date by CRL 9 weeks, 1 day. Appropriate. Anomaly scan is also normal, and growth scan is also normal. So you see, what would have happened if I would not have dated this lady appropriately? And let me tell you, this lady is none other than my wife, and this scan is of my son. So if I would not have dated appropriately, I would have delivered my own son prematurely, or maybe I would have labeled my own son as a SGA or an FGR fetus. So this is the importance of dating. So you have to date appropriately. And again, I'm reiterating it. When I say appropriately, that means it has to be by ultrasound, TVS, and once you have given the EDD, you should not change it again. So the take home from dating part is only TVS between 6 to 10 weeks. CRL is the best predictor of gestational age. We all know about that. Once assigned, please don't change the EDD in subsequent scans. I think I must have reiterated this at least half a dozen times, and I have made my point clear here. And from tomorrow onwards, those who are giving 2 EDDs or those who are changing the EDDs will not do that. And also one important thing is always have a look at the previous scan. That is also very important. At times when the lady comes to us, for an anomaly scan, we simply put her LMP and start doing the scan. And then we realize, oh, that the growth parameters are lagging. But then we have to go back to the file and see if she was dated previously somewhere else, and if they have corrected the EDD. And if they have done so, whether they have done it appropriately or not, whether the images were done on TVS and whether the scanning was done by TVS or not. And only then you take that EDD as final and move on, right? So I hope I've made my point clear about the dating part. Moving ahead, we should also know a few normal variants in the first trimester that we typically get. Say, for example, the first one, the image on the left-hand side, is it a normal pregnancy, normal intrauterine pregnancy, or an abnormal pregnancy? In the chat box, the image on the left-hand side. Is it normal? Yes, it is normal. Somebody said cornual. Interesting. Very nice. Angular. Perfect. Cornual pregnancy. Very nice. So that's why the reason why I'm doing it interactive is because everybody would get to know that, this is not a cornual pregnancy. This is a normal intrauterine pregnancy, which is eccentrically located, just an eccentrically located pregnancy. Previously, they used to call this as an angular pregnancy. Now, according to the SRU guidelines that I have just showed a few slides back, this is no more considered or no more labeled as an angular pregnancy. You simply have to write that it is an eccentrically located intrauterine normal pregnancy. 80% of these pregnancies will have a normal outcome, and we should encourage these pregnancies to continue. At the most, a few patients may have, say, suppose few fetuses may have growth restriction, or they may be adherent placentae, but that does not warrant a termination. So the image on the left-hand side is not a cornual pregnancy. It is a proper intrauterine pregnancy, just that it is eccentrically located. Okay. Whereas the image on the right-hand side, previously they used to call this as a cornual pregnancy. Now they say that you should not call it as a cornual pregnancy. Instead, you should say that it is a intrauterine gestational sac located in a right horn of a septate or a subseptate uterus. Do not call it as cornual pregnancy, because the consultant may take it as an ectopic, and this pregnancy may unnecessarily be subjected for a termination. That should not happen. So this is also a normal. This is just a variant pregnancy which is located in one of the horns of the uterus, having an underlying Mullerian abnormality. Now, you should also know your timeline, like what are the structures which we can see early in the pregnancy. Say, for example, this is a 8-weeker fetus, and you can clearly see 1, 2, 3. Those are the brain vesicles which are clearly seen by the time the fetus is 8 weeks. So also, you can also document the limb buds at around 8 to 9 weeks of pregnancy. So all these things are very easily seen if you're doing a transvaginal scan. So this is a normal timeline. You can also document the spine at around 9 weeks. That's the spinal curvature which we can see. And there are certain things which we are used to seeing even till 11 and a half to 12 weeks, which is the physiological herniation of the gut. That is not an omphalocele. You see a 3D, that is not an omphalocele. This is a normal physiological herniation. Till 50 mm CRL, you can call it as normal. Or in terms of weeks, if you say till 12 weeks, you will call it as normal. It is not abnormal till 12 weeks. It is not abnormal till the CRL is 50 mm. Only way when it is abnormal before 50 mm is if you see a lever in the herniation, or if you see the heart in the herniation, only then it is pathological. Otherwise, this is very normal. You should not write this as an exomphalos, omphalocele, not now, not at 11 weeks. Wait till 50 mm, wait till 12 weeks. Even if then it persists, then you call it as an omphalocele. So this is just physiological herniation. All right, now moving on to the next part, which is early pregnancy loss. Raju sir, am I good so far?
Excellent, sir. Yes, sir. We are, everyone are actually amazed to hear all this, with the responses they are showing.
Wonderful, sir. Thank you.
Thank you, sir. Thank you. Continue.
Thank
Sir.
you. Yeah. So now, moving ahead. Now we'll see what are the criteria for an early pregnancy loss. So if you have a CRL of more than 7 mm with no heartbeat, then you call it as a loss. If the MST is more than 25 mm without an embryo, you call it as a loss. If there is no embryo with cardiac activity for more than 2 weeks after a scan that initially showed a gestational sac, then it is a loss. If there's no embryo with cardiac activity more than 11 days after a scan that showed a G-sac and a yolk sac, then it is a loss. An embryo with no cardiac activity on initial scan and 7 days later is also a loss. And finally, cessation of a previously documented cardiac activity, this is also a loss. This is easily available on the internet. If you want to take a pic of this, you can take a pic. This is easy, but it's very important, when to call the patient for follow-up, when to label it as a loss, when to label it as a pregnancy of uncertain viability. For this, all these parameters are very important. Okay. So now we'll have a look at few case-based scenarios pertaining to loss. So this was the first case. By LMP, this fetus is 10 weeks 1 day. And so this is a video. So this is a big enough fetus, but I cannot see any cardiac activity inside. So what I do is, obviously, I will measure the CRL. Here the CRL is 15.8 mm or say 1.5 centimeters. The gestational age is around 8 weeks. And on M mode or spectral Doppler, I could not document any cardiac activity. So the thing is, this lady is actually married since married life is 5 years, does not have any previous child. So she's saying, oh, doctor, can we not wait for another week? So would you give her that opportunity of waiting for another week? Do you want to wait for another week in this case? Yeah, excellent. No is the answer. So once you have an embryo which is more than 7 mm, and if it does not show any cardiac activity, there is no point in waiting. I understand, I sympathize with her that she has a married life of more than 5 years, but this is an unfortunate thing. This is an unfortunate event of an early pregnancy loss. No point in waiting any further. You can write this as an early pregnancy loss. Moving on to the next case. So this herein we can see a gestational sac-like structure. There was no yolk sac at this point of time. This scan was done and the GSAC was measuring 5 weeks, 5 days. And that's the video. The scan was done on 16th of December 2023. You can read the date here. Raju sir, is my cursor visible?
No, sir. No, sir. Someone
Oh,
started
okay, never mind.
annotating,
No
so
problem.
please stop annotating. I request the members who have joined.
So on 16th of December, we do not have any yolk sac or an embryonic pole in this site, in this scan. So how many weeks or how many days later do you want me to call her? 7 days, 11 days, 14 days? Only GSAC is seen. Chat box. 14 days, 14 days. Wonderful. Yes. So wonderful. So this lady came on 16th of December, and when I called her after 14 days, she did come back on 1st of January 2024. So that was precisely, say, 15 days from the time of her first scan. And now I can see only a gestational sac. There is no yolk sac. There is no embryonic pole. No waiting any further. This is of early pregnancy loss. So you can write this as an early pregnancy loss. Moving on to
Sir, your
case.
marker is not seen, sir. Yeah. Cursor.
Okay, sir. I have nothing to point out, sir, as of now.
Okay, okay.
Whenever
No,
I have
sir.
to point out, I'll use the marker, sir.
Yeah.
Otherwise, my videos are not playing actually. Now can you see, sir?
No, sir. Marker.
It's okay, sir. Whenever I have to point, I'll point it out, sir.
Sure.
Yeah. So in this case, this lady came to us on 17th of August 2023. She has a GSAC and a yolk sac. We have measured the mean sac diameter. There is no embryonic pole. So again, obviously, you call her after 11 days. But we don't typically call them after 11 days. We just, call them, practically we call them after 2 weeks only. So 2 weeks later, she came back on. So this was the 17th of August ka video. You can see a small gestational sac and a yolk sac. That's the yolk sac, no embryonic pole. And the same lady, you have a look at the ID. It's the same ID. The same lady comes after 14 days on 31st of August. And now we can see that the yolk sac is collapsed. The GSAC also appears to be irregular at certain points, and there is no embryonic pole with cardiac activity. So this is another case of early pregnancy loss. Moving on to the next case. Now these things can increase the risk of a pregnancy loss. So this is a subchorionic hemorrhage, a subchorionic collection, which is seen just behind the gestational sac. There is a nice GSAC, yolk sac, but there is a huge subchorionic collection also. So in such situations, you need to put it on the paper that there is a subchorionic collection. And in these fetuses, there is a slightly increased risk of loss. Not all of them will lose, but a few of them may. So it is a good point that to note it down and to put it on the paper. But make sure that you do not scare the lady unnecessarily. Most of them will do good. Only in certain situations there will be a problem. But then because you have seen it, it's better to write it down in your report. There may be some situations such as this. So we have a G sac, a yolk sac, and embryonic pole. So is there anything which is striking in this scan? I will also give you one more image to have a look. I have measured the mean sac diameter also. So is this a normal thing? Will you just straight away, if the cardiac activity is present, will you? Yeah, excellent. GSAC appears to be small. Sweta madam has written. Wonderful. So typically, if we measure the CRL, there is no need to measure the mean sac diameter. But in this case, I have actually measured the mean sac diameter because, as Sweta madam has rightly picked up, the GSAC appears to be of a smaller size. So then it becomes important for me to do the MSD also. But even if I'm doing the MSD, I will not average my MSD and CRL to date. I will still date only by CRL. I will not average CRL and MSD. I will only date by CRL. But why MSD measurement is important in this case is because if my MSD minus CRL is more than 5 mm, then the pregnancy is more likely to continue. If it is less than 5 mm, then the pregnancy is more likely to fail. Okay. So have a look at this case. So that's the G sac, that's the yolk sac. Just on eyeballing itself, you know that the sac is small. Although I can see the embryo and the cardiac activity, but the sac appears to be small. So that's the importance of a G-sac measurement in the presence of an embryo. If you feel that the sac is small, you measure the mean sac diameter. Whatever is the mean sac diameter, say suppose if your mean sac diameter is, in this case, it was 8.7 mm and the CRL is 6.9 mm. So we'll round it up. Say suppose if the G-sac diameter was 10 mm and the CRL was 7 mm. So 10 minus 7 is 3. 3 is less than 5. So whenever it is less than 5, the chances of a loss are more. Okay. When it is more than 5, then the chances of continuation of that pregnancy are more. Okay. So that's the importance of measuring MSD in the presence of CRL. Moving on. Is there a problem in this image? Is it a normal pregnancy or there's a problem? Yeah, yolk sac is big. So many people have written as yolk sac is big. So I'd like to ask you, what is the criteria for a large yolk sac? Yolk sac more than 10 mm. Okay. 9 mm, more than 7 mm. Bigger yolk sac. Okay. Greater than 7 mm. Oh, so which one is the correct reading? The image on the left hand side or the image on the right hand side? On the left hand side, it reads 5.2 mm. So many people said that more than 7 mm is abnormal, right? So, sorry. So the image on the left hand side is 5.2 mm. The image on the right hand side is 7.1 mm. More than 6 mm, some people are writing. So which one is the abnormal one, right one or the left one? It is the same yolk sac which I have measured. In the first image, I have measured inner to inner, and the second image I have measured outer to outer. So we must know that for inner to inner, the criteria is 4.5 mm. So if it is more than 4.5 mm inner to inner, then it is a large yolk sac. Whereas if it is more than 6 mm outer to outer, then it is a large yolk sac. So that's the importance of the measurement of the yolk sac. They are generally, not generally, but in few of them, it may be associated with the early pregnancy loss, or they may have some chromosomal abnormality in the developing embryo. So this same case, this is the video. Have a look at the video. You can see that the yolk sac is large, but there's one more finding. If you guys can pick it up, I'll be extremely happy. So if you see very well, fibroid, fibroid, okay. Okay, there's no fibroid actually, but if you see, the sac is located on one of the sides, it is located at one of the angles, and it is not purely in the midline. You see, in the midline, if you see my midline, the endometrium is continuous with the endocervical canal, and at that point of time, I do not see a gestational sac. Instead, when I go to one of the sides, when I go towards one of the angles, I can see the gestational sac. And these are the situations, your antennae should be up. These are the situations wherein we should do a 3D, and we will get to see something like this. So this was the image which I have shown previously. This is the same pregnancy. What I can see is a gestational sac, but located eccentrically at one of the angles. So this was actually an angular, previously erstwhile called as an angular pregnancy. Now we call it as an eccentrically located intrauterine pregnancy, but having a large yolk sac. Next is this. I'm sure many of you would identify this, obviously. There are things which I have measured. How to differentiate between this and Cornwall's, since they can be fatal if they rupture. Okay, Aditya sir, I'll explain that once I'm done with the presentation. Renu madam, yeah, chorionic bump. Yes, these are chorionic bumps. They represent hemorrhage, and they also have slightly increased risk of miscarriage. So if you're seeing chorionic bumps, particularly if the lady comes to you with bleeding in early pregnancy, we should report them, and we should put these pregnancies under surveillance. But do not scare them. Please do not scare them. Not all of them will lose the pregnancy. Then you may have certain normal variants, such as this. You can see a nice normal embryo with a cord cyst. You see there's a tiny cyst there. Many of them would disappear as the pregnancy advances. Should they persist in the second trimester, and if there are other markers also, then it may be considered as a marker for chromosomal abnormalities. Otherwise, you can leave them on their own. They will disappear by the time the lady comes back to you at NT scan, if not at most at the time of anomaly scan. Then we may have situations such as this. There is obviously an intrauterine contraceptive device inside. With the device, the lady is still pregnant. Now, most of us attending this webinar are obstetricians, and I need not talk about the management of this. But this is another situation which is not very common, but yes, we do encounter these things once in a while. So this is an IUCD with a live intrauterine pregnancy. I will not talk anything about ectopic because that's a completely different topic altogether. And Raju sir is a master about it, so it's better that I do not talk about ectopics. Now, moving on to certain abnormalities that we can pick up as early as in the first trimester. Can somebody tell me what is the abnormality here? There is only one video which is playing, and that is on the left-hand side, lower video. Yeah, ectopia cordis, excellent. Ectopia cordis, wonderful. Yes, so we have picked it up as early as 8 weeks, 2 days, and that's not the first or the only case that we have picked up. You see this also. This was at around 9 weeks. And if you have a closer look, we know by 8 weeks itself, we should have a nice 3 brain vesicles. Here, the complete embryo appears to be very dysmorphic. This is another one which we picked up at 7 weeks. You can see clearly that the cardiac activity is completely outside the embryo. So is it so that I'm living in an ectopia cordis endemic area? No, that is not the case. These things are possible only when you do a transvaginal scan for all your dating for all your datings, Otherwise, most of them will not even reach the NT scan. Most of them will, will miscarry on their own in another week or 2 if you have a habit of doing a TAS scan. So if you want to pick up such abnormalities, you have to do a transvaginal scan as your first choice scan for your dating. So we made a paper out of this and we published this in the Journal of Fetal Medicine. The journal actually replied to me that, we cannot do a paper for this, but then they said that because the findings are unequivocal, they finally agreed and they said they made a paper, because on still image, you cannot say that this is ectopia cordis. The only way you can say this is ectopia cordis is by showing a video. So thanks to them, they accepted our paper. So if you are very careful in scanning, and if you have this habit of doing a TVS scan for all your datings, you may pick up abnormalities such as this also, which may be transient also, you never know. But can somebody tell me what is the finding in this embryo? Shraddha madam has written body stock. Okay. Short limb birds. See, it's 9 weeks, 3 days. So limb birds of this size are pretty much normal. Anencephaly, no. Okay. Never mind. Have a look at the cardiac activity. So there is a slight pause. There is a slight pause in the, arrhythmia. Yeah. There is an ectopic beat or whatever we call it as. It will be very, early to call this as a arrhythmia or an ectopic beat. What I can say now is there is a transient pause in between. Otherwise, the fetus appears to be normal. So it may resolve on its own also, or it may progress. We don't know. This lady did not follow up with us later, but this is just a simple finding. If we are careful enough, we can pick it up. And once we pick it up, we can put it in the report paper also. So that was the M mode which we did. And if you can see, these are the normal beats, and then there is a pause, and then again the normal beats resume. So these things can also be picked up if you are used to doing transvaginal scans and if you're careful enough. Now this is one more embryo, and I would again like or invite you guys to tell me what are your findings in this case. I'll play it again. Okay, big yolk sac, wonderful. Shraddha madam has said one, there is big yolk sac. I would say there are at least 2 more findings. So big yolk sac is one. There are 2 more findings. Ectopia cordis, excellent. And how's the heart rate? The heart rate is slow. Yes. So you guys have picked it up wonderfully. So these pregnancies are at increased, risk of miscarriage. So you see the heart rate is slow. So there are 3 beats. Then there is a huge loss. Then there are pause, and then there are 3 beats again. So this is at 8 weeks, 6 days. Although the embryo does not appear to be a 8-week embryo, certainly a dysmorphic embryo with ectopia cordis, large yolk sac, and a slow heart rate with some rhythm disturbance. So moral of the story, if we are careful enough, we can pick up all these subtle abnormalities. And even if we are not so careful, we should not be missing out on abnormalities such as this. Can somebody tell me what is this? This is a 3D which I have done. Anencephaly. Excellent. So this was not actually a 13-weeker. This is just a 8 weeks, 3 days fetus, CRL 19 mm. There is no skull. So this is acrania. Typically, the skull vault ossification will start at 8 weeks, and we have already seen that for 8 weeks, we should see good 3 brain vesicles. So here, that is a normal 8-weeker. So this is a normal 8-weeker developing embryo, which clearly shows us the 3 nice brain vesicles. Whereas if you see the embryo on the left-hand side, it does not have any cardiac activity. And also there is no skull vault ossification. And there is increased amount of echoes in the amniotic cavity, which indicates that this is a neural tube defect. So this was picked up as early as around, definitely it would be a 13-weeker, but it has lost earlier only. So yes, that's it about early pregnancy loss, few cases and dating. moving on to twins now. So this is a true and false. Okay, we have to attend. Almost all dizygotics are dichorionics. This is whether this is true or false. Almost all monochorionics are monozygotics. Number of gestational sac is equal to chorionicity. Different gender means dizygotics. And IVF pregnancy is correctly dated by LMP. So which of these are true and which of these are false? You may write in numbers, say 1, 2, 3, 4, like that. Okay, Rashmi madam has said 4 different gender means dizygotic. 1, 2, 4 are true. Mrunali madam says all are true. 1, 3, 5 are true. Okay. Santosh sir says 1, 3, 5 are true. Wonderful. So we'll move ahead. We'll see which are true and which one is false. So first of all, we should know what are the types of twinning. Okay. Dizygotic. What does this mean? So you see, one ovum and one sperm, if they fertilize, they will form one embryo, one zygote, right? Two sperms, if they fertilize two ova, then they will form two zygotes. So that is your dizygotic pregnancy. So obviously, dizygotics will have, they are like two separate individuals living in one uterus, correct? So these are also called as fraternal twins. So one sperm fertilizing one ovum, another sperm fertilizing another ovum. They are responsible for causing two separate embryos in one uterus. So obviously they will have two separate placenta. They may or may not have separate genders. Okay, so this is dizygotic pregnancy. Whereas in monozygotic, what happens is, now there is only one embryo. Okay, there is only one embryo which is splitting. Now, if the splitting happens before 3 days, nothing is shared, everything is separate. So they will be having separate placentae. So these will be dichorionic and diamniotic. I'm reiterating, if the splitting happens before 3 days, nothing is shared, everything is separate. So they will have separate placentae. Each of them will have a separate placenta, and then they will be dichorionic and diamniotic. But if the splitting happens after 3 days, say between 4 to 8 days, then the placenta is already formed. Now you cannot, there is no way out. You have to share the placenta. So they will be monochorionic, but they will be diamniotic. If the splitting happens after 8 days, from 8 days to 12 days or 13 days, now even amnion cannot be separate. So there will be only monochorionic and monoamniotic. Everything needs to be shared. And if the splitting happens after 13 days, then they are conjoined twins. So if it is a monochorionic pregnancy, that means by default, it is a monozygotic pregnancy. So all monochorionic pregnancies are monozygotic pregnancies. Is it important for us to know the zygosity and the chorionicity? Yes, it is important. And we'll see later on why it is important. How to identify the chorionicity at the first place? So in DCDA, we will have a thick membrane. The intertwin membrane will be thick. There will be a full lambda. The number of placental masses may be 2. See, I've given a star there, okay? Because even MCDAs may have, 3% of MCDAs may have 2 placentae. So one cannot completely rely upon the number of placental masses. And important is gender discordancy. Although PCPNT in our country, we do not go by we do not have a look at the gender, but different gender means by default, they are dizygotics. But if they are same gender, then they may be dizygotic also or monozygotic also. But different gender means they are dizygotics. And then by default, they will be dichorionic. So if they have a gender discordance, then they are dichorionic twins. But if the gender is same, you cannot say that they are monochorionic. They may still be dichorionic. We never know, because most of them are anyways dichorionic. 6 out of 7 twins will be dichorionic. Only one will be monochorionic when you have a problem. Okay. If you cannot ascertain the chorionicity by TAS, you do a TVS. Okay. If you still cannot ascertain the chorionicity, you refer the patient to a higher center. if the higher center also cannot ascertain the chorionicity, it is better to assume that they are monochorionics and treat them accordingly. Okay, good. Now we'll see a few cases about chorionicity also. So this is 11 weeks, 6 days, twin. You can clearly see a nice placenta and a thick lambda. Can you see a thick lambda? I hope it is visible. So that's the chorion and a thick lambda. The whatever color that is, that color is the amnion. So that was a dichorionic diamniotic pregnancy. Whereas in this case, you can see the chorion marked in yellow. But if you see the amnion, this is a empty lambda or a T sign. There is nothing going into the intertwin membrane, and also the intertwin membrane is thin. So that's a case of monochorionic diamniotic pregnancy. Okay, so this is clear now, right? Good. So we'll move on to a few cases. So this is the first case. How many gestational sacs do we have? How many gestational sacs do we have? We have 2 gestational sacs. So 2 gestational sacs means it is dichorionic pregnancy. Simple as that. Very nice. And here we can clearly see that there is a thick lambda, thick intertwin membrane. So this is a case of dichorionic diamniotic pregnancy. Okay. Next is this. How many gestational sacs do we have here? We have only 1 gestational sac, but we have 2 yolk sacs, 2 amniotic cavities, and 2 embryos. So number of gestational sac means your chorionicity. So if there is only 1 gestational sac, that means this is a monochorionic pregnancy. And because you have 2 yolk sacs, so 2 yolk sac means it's a diamniotic pregnancy. Although it is arguable, but you can still say, because you can see the 2 amniotic cavities and the 2 embryos very well. Okay. So this is a monochorionic diamniotic pregnancy. Similarly, when they come to you for NT scan directly, what you can see here is see the empty lambda there, right? There is nothing going inside. Thin intertwin membrane. So this is a monochorionic diamniotic pregnancy. Okay. Next case. This is not my case. This is given to be by my colleague, Dr. Yogesh Saudhary, sir. So it is his clinic, Bhakti Sonography Clinic. Can you tell me what is this case? We have only 1 gestational sac. Yeah, MCMA. Yeah, obviously MCMA, correct sequence. Now DCDA, MCDA, what remains is MCMA. Conjoint, Lalita madam, no, this is not conjoint. This is MCMA. And the hallmark of MCMA is, you see the cord. This is cord entanglement. Cord entanglement is a feature of MCMAs. So this is an MCMA pregnancy. I do not have an MCMA pregnancy of my own because they are rare. Okay. So important thing is, if you are into if you are into if you are a second opinion clinic, if you are a second referral or a tertiary referral center, and if your staff tells you that there is a patient who has come to you for opinion, outside scan says it's a monochorionic monoamniotic pregnancy, what will you do? You are yet to see the patient. Your staff says that the outside report says it's a monochorionic monoamniotic pregnancy. What will you do? Even before scan, will you tell something to yourself? You have to tell yourself that just see the images. If they are TAS, then you do not rely, because MCMA, for all practical purposes, they do not exist. I mean, they do exist, but they actually do not. They are not very common. MCMAs are not very common. I have never seen 1 MCMA in my entire practice. I don't have a 30-40 years ka practice, but still MCMAs are very rare. So the first thing that you should tell yourself is, have a look at the images. If they are TAS images, then you know that for sure they are not MCMAs. You just have to do a TVS and document the intertwin membrane. And if there is no intertwin membrane, you document the cord entanglement, and only then you call it as MCMA pregnancy. Yeah, always Karthik sir and Santosh sir. Yes. always prefer TVS. This is even a higher order pregnancy. How many gestational sacs do we see here? 2. So this is a dichorionic pregnancy, right? But how many embryos do we see inside? 3. So this is, and 3 yolk sacs also. So this is a dichorionic triamniotic pregnancy, right? Wonderful, easy one. So that's about chorionicity. It is absolutely important to mention the chorionicity if you're doing twins. If you do not report chorionicity in your twinning report, your report is pure waste. Sorry, I'm talking harshly, but a twin report without chorionicity mentioned in that report is actually a waste. So if you cannot report chorionicity, you please refer them to a higher center, but just simply don't write that this is a twin intrauterine gestation. For all twin intrauterine gestations, it is mandatory that we should mention the chorionicity. That is it. Without chorionicity, your report is of no use. So chorionicity is of paramount importance, okay? Because DCDAs they are better twins. MCDAs have a different set of problems. We all know them, TTTS, TAPS and all, SFGR and all them. So their monitoring is also different. That's why chorionicity is of paramount importance. Now, moving on to the next thing, that is dating in twin pregnancy. How do we date the twins? Ideally, we should do before 13 plus 6 weeks. Spontaneous, if the lady conceives spontaneously, then we should use CRL or the head circumference. If the discrepancies, obviously, if there is inter-twin discrepancy, then the CRL of the bigger twin should be considered. Many a times I see this, that twin intrauterine pregnancy, twin A measuring, twin A is 9 weeks, 2 days. Twin B is 8 weeks, 5 days. Now, what do you want me to do? Shall I deliver the twin A on 31st of December and then the twin B on 2nd of January? No, that's not going to happen. So no point in giving 2 different gestational ages, 2 different EDDs. There is only one gestational age for twins, and that is the gestational age of the bigger twin. So no 2 EDDs, no 2 gestational ages for twin, only the gestational age of the bigger twin. And if there is IVF, then you calculate them by LMP, because LMP is used for spontaneous conceptions, whereas IVF, we have to date them by date of conception. How do you calculate date of conception? All of us know. Say, suppose if the embryo was transferred today, which is 3rd of September, or imagine today is 5th of September. If the embryo was transferred today, and if it was a day 5 transfer, then you subtract 5 days, and then whatever is the date, you put it as date of conception. Imagine this situation, like the embryo was transferred on 6th of September and it was a day 5 transfer. So the date of conception would be 1st of September. Likewise, if it's a day 3 transfer, you subtract 3 days. If the transfer was done on 6th of September and if it was a day 3 transfer, you subtract 3 days and your answer is 3. So the date of conception was 3rd of September. Okay, and in the machines, all the machines, say lower end machines, mid-range machines, and the higher end machines, so obviously they have a date of conception wala column. So if we know how to calculate the date of conception, we can put it, and then we can use this date as the date for all the subsequent scans. One last point about labeling of the twins. One should not label the twins alone by a single parameter. You know, we should use multiple things. Like many people I see that they'll write twin 1 on the right side, twin 1 left, up, down. So that's not the only way. You have to use multiple things. So no, otherwise next time when you see, you will only be confused which is twin A and which is twin B. So how to label the twin is you look for discordance for anomalies. Say suppose if one twin has a single umbilical artery, it becomes an easier point to identify the twin the next time you scan. Look for the cord insertion on the placenta. One twin may have marginal insertion, one twin may have an eccentric or a filamentous insertion. Likewise, you talk. Look for discordance for growth and gender. Obviously, it's not for our country. Finally, you should use combination of features. Say, suppose how I would label the twin is twin A has an anterior placenta, is closer to the internal os, is on maternal left side, has a single umbilical artery. So I've used multiple features to label this twin so that next time when I see this twin, I do not make any mistakes. Okay. So coming back to the questions which I asked previously, now here's the key. Almost all dizygotics are dichorionics. That is true because they are two separate zygotes. So they will obviously have two separate placentae. So all dizygotics are dichorionics. That is true. All monochorionics are monozygotics. We've already seen that. If you have only one placenta, that means they are monochorionic. I mean, if you have ascertained the chorionicity, okay, one placenta may be fused placenta also. But if they are monochorionics, then they are almost always monozygotics. Number of gestational sac is equal to the chorionicity. Different gender means dizygotic twins. And IVF pregnancies have to be dated by the date of conception. So that is the key for the question which I have asked. So the take-home message from the entire talk is, I hope you guys know this, he is Thor. And the hammer that he has in his hand is known as Mjolnir. This is me. That's the hammer, which I don't have. This is my Mjolnir. This is my TVS probe. So the entire session which we have done is all by TVS. Without TVS, you cannot do anything in the first trimester. Moral of the story, the only one thing which you have to take home from this entire discussion is TVS. That's it. Okay. I hope I've made my points clear. If there are any doubts, I'm ready to answer them.
Sir, shall we take up some few questions, sir?
Yes.
From the
Thank you
chat
so very
box,
much
I
for
used
the
to write
opportunity.
down some of those. So,
Yes, sir.
first thing, one of the members asked, why can't we use the Doppler in so early pregnancy? Because you told about only usage of the M mode for the heart rate.
Yeah.
So,
Safety issues, sir.
yes, sir. Yeah, that is what.
Literature says that it is not recommended and it is not safe so early in the pregnancy.
Yes, sir. And one more was Aditya sir asked about again. You have clarified it. That the difference between the angular and the cornal, as you can elaborate, because angular is no more in your the
Yeah,
word now.
angular is no
Yeah.
more used. Yes, sir.
Yes.
Instead, we should write eccentrically located intrauterine
Intrauterine.
pregnancy.
Very nice.
Cornal pregnancy, they used to write previously. You know, cornal was a term which was used for everything. It was used for angular also. It was used for interstitial also. And it was used for a pregnancy which is in one of the horns of an underlying Mullerian abnormality.
Sir, yes, sir.
So
Exactly.
this can unnecessarily cause confusion. So
Yes, sir.
instead of this, a better practice is you describe where is the pregnancy. And another way can be you give a 3D. And what I generally do is I'll actually draw a figure on the report, like how Raju sir
Exactly,
does.
sir.
Pretty much
That
inspired from
really
him.
gives a
You
better
draw a
depiction
figure.
of your, yeah, yes, sir.
Yeah.
Yes, sir. Very nice. Because and also the sideness also will come to know if it is a septate uterus or a bicornuate uterus, which side or which horn is the pregnancy. Yes, sir. Yes, sir. The diagrams will play a very important role. And next, one of those asked, what is the cutoff of subchorionic hemorrhage, and when do you call it as an which will lead on to an impending miscarriage?
So there are no such cutoffs, sir, as such.
Yeah.
Just on
Yes, sir.
eyeballing, if you feel that if it is covering, say, more than 2/3 or more than half of the circumference of the
more than
gestational
half.
sac, then then it is worth mentioning it because they are the ones which are more likely to miscarry.
Sure, sir. Sir, large gestational sac, any significance?
Not to my knowledge, sir. Maybe I'll have to read more about it. Some people say that they can lead to polyhydramnios in the later half of the pregnancy, but
Yes.
I couldn't find any literature on that, or maybe my research was inadequate. I will find about it and I'll give an answer to it later on, sir.
Sir, thank you, sir. How do you label? Okay, this was actually you took it later. The labeling of the multifetal, it is not on only one parameter. And as you can come and see some few questions now. Best time to tell about the chorionicity is like the very early when you showed in very beautifully in the very early pregnancies when you have two different gestational sacs and apart. Yes, sir. And some few more are popping up now. Any thickness of myometrium taken to differentiate eccentric and interstitial? Yes, sir. Interstitial is yes, sir.
Eccentrically located pregnancy is a true intra-endometrial pregnancy. If you do not have the pregnancy in the endometrial cavity,
Yes, sir.
toward one of the cornu.
Yes,
It
sir.
is in the uterus, but it is outside the endometrial cavity.
Yeah,
Then it is an interstitial pregnancy.
correct, sir. Yes, sir. When you have it outside the endometrial borders and well within the serosa, but it is just before the serosal borders, then okay, when it is separate from the endometrial cavity, yes, sir, it is interstitial. Sir, is it possible that if patient comes first time at 18 weeks with posterior placenta, we can't determine the chorionicity?
Yeah, very much possible.
Yes, sir. Yes, sir.
So first
Definitely.
thing is, if the patient comes to you for the first time at anomaly scan, you ask them if they have done any scan outside.
Yes.
More often than not, they would have done a scan outside, and you
Yeah.
don't see the report. You don't see the report. You see the images.
Images.
If
Yes.
there are two gestational sacs, you label it as dichorionic. And if the images are also not available, or say suppose if the lady has not done any scan outside, okay,
Yes,
this
sir.
is the first time that he has come to you, and that is, say suppose that for an anomaly scan, and if you have a single placenta, it is, by PCPNDT, you should not be looking at the gender.
Yes.
But if by mistake you happen to do so, and if there is discordance of gender, then
Yes.
they are dichorionic and the
Correct.
placentae are fused. Okay. But if the gender is concordant, then by no means you can tell that this is a dichorionic pregnancy.
Yes, sir. We cannot.
So the only way in such a situation is assume that they are monochorionic, and you do the follow-up according to the monochorionic guidelines, which is
Yeah.
every 2
Yes, sir.
weeks you have to see the feed.
If you are not very sure, then we'll consider even if it is dichorionic, but still we'll monitor as a monochorionic pair. Yes, sir. Thank you, sir. How to differentiate between the endometrial fluid collection and subchorionic collection? Sir, you explained it. You can go ahead, sir, if you want to make more points on that.
No, sir, I've already explained, and most
Yeah,
importantly,
you
a
beautifully
subchorionic
explained it.
collection.
Yeah.
Minimal fluid collection can be there, which is of no significance. But if the lady comes to you with bleeding PV, and if you see a subchorionic collection, it will be typically irregular, which will have echoes inside. The lady also
Yes.
gives you the history. Then, if it is more than say half of the circumference, you write it as a subchorionic collection.
Right. Can yolk sac, which has been seen before, disappear after 2 weeks when FHR is absent?
Yes, that is
Yes.
what typically happens in vanishing twins also.
Yes, sir.
Over a period of time, our body will take care of it. Slowly, the yolk sac will disappear. Even in twins, you see, if there are twins to start with, and if one of the twin is non-viable, if you see the pregnancy again after say 2 weeks, 3 weeks, slowly the yolk sac, the G sac, everything disappears. And by the time she reaches NT scan, nothing is seen. So it's a common phenomenon, normal, natural progression.
Yes, sir. Thank you, sir. What do you counsel the patient if large chorioamniotic separation persists after 16 weeks and we find rest everything normal? Any genetic test to be done in such situations? These are, yeah, sir.
The chorioamnion fusion should typically happen by around 16 weeks.
16 weeks.
In certain situations, it may be delayed also. But if the fetus is normal, chorioamniotic separation or say non-fusion does not warrant a testing. I would simply ask her to come back again at anomaly scan. If it still persists, it's okay. I will not do an amnio, or this is not an indication for doing an invasive test.
Right, sir. Yes, sir. Significance of large extra embryonic coelom.
We have already discussed it, sir, before.
Yes, sir. I find it very difficult to differentiate between chorioamniotic separation and subchorionic on USG in the late first trimester. Please tell a simple way to differentiate the chorion and the separation between the subchorionic hemorrhage and separation. It is more obvious. Anything you want to add, sir? Like differentiating points between a chorioamniotic separation and a subchorionic hemorrhage.
Sir, chorion and amnion, they are anyway separate till 16 weeks.
Yes.
It is a normal physiological thing. Chorion and amnion will always be separate till 16 weeks. So it is a normal physiology. If it still persists, then you may say that it is not fused, but eventually it will fuse. Say if you have 24 weeker, and if you see that the chorion and amnion are not fused, they are not actually fused. They are not unfused. This is the point wherein you can say that there is chorioamniotic separation. Till 16 weeks, the separate chorion and separate amnion are normal.
Right. Yes. So Dr. Karthik has added, yes, sir, it is also important to look into that next, like we can look for the maternal kidneys and ovarian masses also that will add to our
Certainly,
first
certainly,
trimester screens.
without a doubt.
Yes, sir, yes. Can we mention chorionicity before appearance of embryo if we see two gestational sacs?
Then, I mean, do you have yolk sac inside? If you do not have yolk sac, then those are not even gestational sacs at the first place. I would not do that. I would rather wait till I get the embryo with cardiac activity.
Yes,
There
sir.
is no hurry as such.
Correct. How to diagnose pre-placental hemorrhage? Like, yeah.
So they are just heterogeneous collections, sir, on the
Yes. Yes, sir.
placental
Yes.
surface towards the fetal part. Yeah.
Yeah. Sir, at the very onset, I would like to thank you so much, sir. It was absolutely brilliant. And in spite of your busy schedule, and you made it here in the last moment. And yes, there are no words actually. And you can actually look, there are very few webinars of us will cross 100. And today, even when we have reached the peak of more than 1 hour, still more than 100 people are logged in. It had reached almost 130 plus. Thank you all members for logging in. That is the reason why I told please join. This is going to be a very interactive, and sir absolutely delivered the same.
Yeah.
Because it was yes, ma'am. Yeah, Shubha Gudi
Yeah,
ma'am wants to
yeah.
tell something.
No,
Ma'am,
no, no. I
thank you.
just wanted to compliment and I wanted to congratulate because I think it was a very fantastic deliberation.
Yes, ma'am.
And it was actually क्या बोलते हैं उसको spellbinding ना nobody
Yes,
moved out I think
yes, ma'am. There was no doubt about it. That
there
is
was
one of the reason I was just posting.
absolutely
So
minute to minute everybody was you
yeah,
know they were hanging on Varun's words I think
yeah.
so extremely well done Varun we are
And the
so
number of
grateful that
So well done.
you gave
responses
time for
we.
Really means a
Kasoga.
lot.
Thank you,
And
sir.
Really
The,
means a
also
lot to
the
me, ma'am. It was a
interaction, my
wonderful
God,
opportunity.
how you have connected to the audience.
everyone,
And,
yes, ma'am. This is,
yes,
I
that
feel this
is
is the only
beautiful.
webinar
Yeah.
we saw so many people were on their touch on
Yeah.
their pads and actually to type.
Yeah, everybody wants to find out, everybody wants to ask you, everybody wants to learn from you. What more we can have? And Raju, really, I compliment you for getting such a wonderful faculty
No,
for
ma'am.
Kasoga.
Yes,
And
ma'am. Yes, ma'am.
God
He
bless
is.
both of you. And may
Thank you
you
so
go
Varun
much,
sir,
from
ma'am.
strength to
Shobha Gudi
strength.
ma'am is our secretary of Kasoga, sir. Yeah, she
Yeah.
Yes,
joined
sir.
late. Yeah, yes. Yes, sir. Yes.
Where is your work, Varun Thakur? Where do you work?
Ma'am, I practice in Pune. On the outskirts of Pune, there is a small area called as Moshi. It is in
Moshi.
Pimp
Okay.
Chinchwad actually.
Okay.
Yeah.
Okay.
So
Okay.
that is where I
You are
practice,
doing
ma'am.
very large volume work. It is obvious.
And he's an
No,
amazing
ma'am, I
teacher,
do.
ma'am. He does work.
I do only 15 cases a day, but
But they are
that's it,
exceptional.
ma'am.
They are exceptional. If you look at his NT images, ma'am, and or whatever it may be, they are absolutely brilliant. And the
Wonderful.
quality of work is outstanding. Thank you so much, sir. We can see
Keep
so
going,
much of
and
message.
Thank you,
we
ma'am.
will source you again,
Yeah, sure,
and we
ma'am. We
will
will hang him with it.
invite you
Many. We
again.
want more
Yes.
from you,
Thank
sir.
Thank
you.
you, ma'am. Thank you. Means a
Thank you
lot.
so much, sir.
Thank you.
We can look.
Thank you very much.
We can actually thank you so much, ma'am. Thank you for logging in and for your
Thank you.
messages. Thank you so much.
Thank you.
We can see so many messages been pouring out, sir. I really thank you and also congratulate you for your deliberation, and you have been doing wonderful work, sir, and also educating us. And this was absolutely needed for us, and such basics with clear concepts. There's a lot of take-home messages. I would like to deliver some few points here. What sir? TVS is the must. TVS is a must, and we cannot do without TVS here. And in fact, you may or may not know, sir does TVS in all trimesters. For example, if you want to look at the cervix there and whatever we want to see, he does TVS in all trimesters. There is no absolute
I
no
hope
contraindication for
intrapartum
that.
also he does.
Yeah,
I
he is a
no, ma'am.
radiologist, ma'am. Yes, we
Intrapartum.
should.
I'm a
He should be
radiologist,
doing.
ma'am.
Yeah, he should. Yeah, yes, ma'am. Yeah.
That is your next milestone, Varun. You must
Yes,
enter the
ma'am.
labor room.
Yes, ma'am. That we will
Certainly,
be
ma'am.
looking
I did
forward. Yeah.
actually when I was an intern, but now,
Mm.
but I'll
Yeah,
try,
it has
ma'am.
got a
Certainly.
huge scope and it might bring down
Yes.
the cesarean section rate. So you will be altering demographies also.
Yeah.
Yes, ma'am.
Okay. So
And
keep
sir
that
has
in
also
mind.
told
Yeah.
about never
Yeah.
change the EDD, that whatever
Yeah.
tips, the practices you follow. A dating scan is very, very important, and how to date the IVF pregnancies as well as especially on the chorionicities and also in multiple fetal gestations. And based on the larger CRL, we have to go for the dating. So all brilliant points you have told and so beautifully delivered, sir. And we can see so many members still logged in. Thank you so much for being out there, sir. Varun, sir. Thanks once again. We
Thank you.
want to
And
have more
Raju,
from
I
you.
hope I can get the recording of this.
Sure, ma'am.
no?
This
Mm.
recording is there. Even the YouTube link was actually sent by Varun.
Yes,
It will be
yes,
there in
yes.
YouTube.
Yes.
And all for those who are asking for the papers, I will try to send the paper, the lexicon paper, what sir was telling about, into the
Please send
groups
it.
that you can send across the members of the local societies or whatever.
Correct. Correct.
And also, I will try to paste that link in the YouTube also. Please watch this video. Those who have missed today, a very important one. You will be sharing the YouTube link. And thank you, Varun sir. It is whatever you have done was a wonderful job. A blockbuster,
Thank
I
you,
can
sir.
call from the society that we are conducting this.
Houseful
Yes,
and
yes, ma'am.
golden jubilee types. Very good. Excellent. I really loved it.
Thank you.
Thank you. Bye.
Thank you, sir. Thank you, Varun sir.
Thank you, Raju sir, for the opportunity. Thank you.
Thank you so much,
Good
sir.
night.
Good night, sir. Arun, thank you so much. We shall call it a end of the session. Thanks, everyone. Thank you for joining.